Good evening, everybody. Thank you so much for joining us tonight. We are the SVN, the Society of Vascular Nurses, and we are proudly taking over the Legs Matters website tonight to bring you all you need to know about peripheral arterial disease. So a couple of things. Firstly, thank you to Legs Matters for allowing the Society of Vascular Nurses to pinch their page for this evening. Thank you for giving up your time. I have with me two fantastic vascular nurses, and they are open to be grilled by you. So if you've got any questions, if you've got any comments, there's no such thing as a daft question. Please just put it into those chat boxes or into the Q&A, and we'll work through those. So it's lovely to have you here this evening. This session is going to be recorded and it is going to go on the SVN website along with the Legs Matters website, so you will be able to watch it back if needed. So without further ado, I would like to invite my two fantastic colleagues with me today. So my first is the president of the Society of Vascular Nurses, Jane. Would you like to introduce yourself, my darling?
Thank you, Leanne. Thank you for that lovely introduction. Yes, I'm Jane Todd-Hunter. I'm a vascular nurse practitioner based in Cumbria, in Carlisle, and I have the lovely joy of being president of the SVN currently and working with a fantastic committee. Delighted to be here this evening, backed up by the lovely Annie.
Annie, over to you. Please introduce yourself.
Thank you very much. So I'm Annie Clothier. I'm one of the vascular nurse specialists in South East Wales, working in Iron Bevan. And I also sit on Legs Matter as one of the vice chairs. I've just taken over that role. So I'm really excited to be on the chat tonight, and I hope we get lots of questions and we can answer all your questions as well. So please send them in.
Perfect. So, and I'm Leanne Atkin. I'm a vascular nurse consultant from Mid York's NHS Trust and also a research fellow at the University of Huddersfield. And it's my delight to be the chair this evening. So I'm going to be grilling my two colleagues and hopefully with your assistance, asking them some of those difficult questions. Please remember, this is a sofa chat. It's meant to be informal. It's not supposed to be like listening to a presentation for an hour. We are a friendly bunch within the SVN. I am so grateful for you putting your names and who you are in that text box, because it just feels like we're not talking to the wall, if you like. It's great to see that we have there's people from Pontypridd, which is somewhere in Wales, exactly. Annie's supporting that. But I can see already we have a huge variation of people right across the multidisciplinary team. I'm seeing nurses from all backgrounds, lymphedema nurses, tissue viabilities, podiatrists. So welcome to you all, and we hope this session will be pertinent to all of you and you'll take some of this home. So today's session is all about peripheral arterial disease. So we're going to start with some of the basics, if that's okay. So Jane, if it's all right, I'd like to start with you. So could you just give us a brief recap? What is peripheral arterial disease and really how is it caused?
Okay, Leanne, thank you. Peripheral arterial disease, it's atherosclerosis of the arteries in the peripheries in the legs, really. And it's that buildup of plaque in the artery itself, which narrows the flow, narrows the lumen of the artery, so it reduces the blood flow, and it may just reduce it, or sometimes it can actually block it, and so from stenosis to blockage. And it's the same disease process that affects the arteries when you get heart disease or you get coronary disease leading to stroke, etc. It's the same disease process, but it's affecting the arteries in the leg.
So what, in terms of the risk factors then, are they the same as the cardiovascular risk factors?
They are indeed, Leanne. They're exactly the same. So those risk factors are unanimous across cardiovascular disease is exactly the same for peripheral arterial disease. So we're looking at those risk factors of diabetes. Of course, smoking is a huge risk factor for atherosclerosis. Increasing age, we can't do anything about that, but that as we age, we get an increased risk factor for peripheral arterial disease. High blood pressure and then high cholesterol is also. And of course, you have that family history of arterial disease, and that can be in any arterial tree. So it can be history of heart attacks, history of strokes. That's relevant for patients when you're considering their risk of peripheral arterial disease as well.
And I think, Jane, we all know about the real increased risk of diabetes and smoking. But I'm really, really surprised every time I look at the figures that actually hypertension as a standalone is a significant risk factor to peripheral arterial disease. And then that sort of links of why primary care is so focused on everybody over 50 having a regular blood pressure. So Annie, over to you if I could. So Jane's really nicely outlined what it is and what's the risk factors to our patients. But what are the symptoms that often patients start with right at the very beginning, let's say, of peripheral arterial disease formation, all the way up to severe peripheral arterial disease? Can you just talk through some of those?
So you might have some patients that will present to you with what we call claudication symptoms. So they will complain of a cramping type sensation in the back of their calf when they're doing exercise. So it might be more apparent when they're going uphill. But the classic thing that they will say is that it stops when I rest. But then when they start going again, the pain will come back. So it's almost, I like to describe it to them as though they've got a heart attack happening in their leg. And then it can progress then to maybe tissue loss. Some patients might experience even a small little fissures on the backs of their heels or around their nail beds is another place that it might occur. It can be very, very painful, take a long time to see any difference with it, non-healing, and they may go on to develop rest pain as well, which is this unrelenting pain that just simply does not go away. And these patients will also describe that they're unable to go to bed, can't elevate their legs at all. The only time that they find any rest is when their legs are down, dangling down. And then we can go on then, we're developing then limb-threatening ischemia, which can present as amputation. And unfortunately, lots of these patients end up coming to us quite late.
And I suppose that's really why we're doing this webinar tonight, that we, as a collective vascular nurses, very much jump to that chronic limb-threatening ischemia. But there's so many patients out there, isn't there, who are living with claudication and never develop chronic limb-threatening ischemia. And there's a group of patients that's actually asymptomatic from their peripheral arterial disease. And I suppose that's why it's really important that we get our community colleagues to really think about that early recognition. So with all of that, so Jane, what would you say in terms of how do you go about first off thinking about how do you recognise these patients within a community setting, and what would your be sort of like key bits that you're trying to pick out of that patient history?
Yeah, I mean, and you're absolutely right, Leanne. It is about that whole patient history, the clinical examination, and then, you know, if you're doing ABPIs, etc. It's that whole package. So the patient history for me, the things that I tend to ask about are those risk factors that we've discussed. So, you know, are you a smoker? Have you been a lifelong smoker? That immediately increases their risk for peripheral arterial disease. If you've got diabetes, you further increased your risk, and obviously your blood pressure, like we talked about. So in that patient history, I'm really looking closely at those risk factors manifested within the patients. I'm looking at their family history as well. And then you start to ask those questions when you're probing the symptoms. So you're starting to ask patients, what's your walking like? How fast do you walk? You know, can you walk 50 yards, 100 yards before you would have to stop? Do you get pain in your calf muscles that stops you when you're walking and eases with rest? So you're looking very specifically for those claudication symptoms. And then you start to, exactly what Annie has said, you start to look a little bit further to make sure it hasn't moved into something a bit more serious and moving into that chronic limb-threatening ischemia where they're getting rest pain, or if they have tissue loss to their toes and feet. So I suppose it's about that whole package, really, that you're looking at in that sort of questioning of the patients.
And it's that repeatability, isn't it, really, of intermittent claudication? It's every single time that they walk. It's not here and there and it comes and it goes, because there's so many different things that can present as lower limb pain. You know, we get a lot of patients referred from generalized cramping, and there's a lot of musculoskeletal differential diagnosis that can go along with this. Gail Curran is listening tonight, who is our ex-president of the Society of Vascular Nurses, and asks a great question. And something that I learned even last year at our amazing conference about how you can differentiate between arterial claudication and spinal claudication. So what did we all take away from that session that we heard last year? Annie, do you want to take
the shopping trolley?
The shopping trolley. So explain that to the audience if you can.
So if you're walking along, but you're able to bend over with your shopping trolley and your pain goes because you've opened up that spinal canal, then that would indicate then that it's not an intermittent claudication in the lower leg. But if the pain is still there when you're doing that, then it's good.
And what a great take-home tip that all of us, when she said that to us, we had a brilliant physiotherapist last year at our conference who told us all of that, and we all went, oh, that's a good one, isn't it?
It's brilliant.
Because I find it really confusing that it's called spinal claudication. And when I first came to be a vascular nurse, I thought it were about the blood supply to the spine. Not actually, in a way it is, but it's about that cavity within that spine. It's got nothing to do with peripheral arterial disease in a way. So I often think that's a really interesting one. I suppose the other thing, though, is, Jane, when you talked about how arterial disease is formed, you said sometimes you can get a blockage within the artery. Now, there's only one major artery going down your leg. So if you get a blockage within your artery, is that always needs significant intervention? So if I see a patient and I cannot feel a foot pulse whatsoever, and the patient's saying that the foot looks a bit whiter and a bit colder, does that mean that this is the start of something terrible that I need to escalate now?
Again, it's not just about the foot, isn't it? It's about the symptoms that they're experiencing with that foot. So if they're getting rest pain and they have tissue loss and they have a white cold foot, then yes, you absolutely must escalate that immediately. If they have a cool foot and they have no rest pain and they can walk and their quality of life is fine and their stitches are intact, then no, you don't. And you mentioned about the main artery in the leg narrowing or blocking. And often what we try to promote through our exercise programs is that build-up of a collateral system. So really what you're wanting your patients to do is to really promote angiogenesis of a little bypass system around the blockage.
I know. What's angiogenesis, Jane?
Just that new growth of vessel, isn't it? That developing of smaller vessels into something that can support, like a little network of vessels that can support the blockage. And it'll never carry the amount of blood that main artery carried, but it might be sufficient to keep that patient ticking along quite nicely without ever needing an intervention. And we're really trying to promote this development of collateral blood supply for our patients with peripheral arterial disease. And this is, how we drive the reduction in smoking to give the body a chance to do that. We, try to keep their HbA1c, that really good diabetic control to allow the body to do that. And we really try to promote that walking that's going to encourage that new vessel development, really.
So hold that thought, if you like, because we're going to come on to in a little bit in terms of that, why is exercise therapy so important. But when I first came into vascular, I often thought, if their artery is fully blocked, a long length artery blockage, why isn't that foot dropping off? And I think we have to remember how arterial disease is formed. It's not blocked off straight away. If it was, that'd be acute limb ischemia. This artery is narrowed through that atheroma formation over weeks/months/years, and therefore the body's had a chance to reroute, if you like. So if the motorway is blocked, the body starts to regrow those B roads around the blockage. And that's what Jane is saying in terms of why many of these patients don't need actually vascular intervention. What they need is good community management. And we'll come back to that in a little while. So you've really highlighted, the pair of you, that the most important thing with all of this diagnosis is the patient history, listening to the patient with those little Miss Marple ears, if you like, of thinking of what coming. Once you've got that, I suppose, what other parts of that key assessment is within your armoury that you think is essential in helping to diagnose these patients with suspected peripheral arterial disease?
I was going to say, well, we look at things like pulse palpation is a real indicator for us. And obviously, depending on where you can feel the pulses in that limb would indicate to us if there's a problem. Obviously, we've got other tests such as ABPI, but we're not solely focused on the results of the ABPI, but it does give us an indication. But as Jane said, looking at the patient history, I think, is absolutely one of the most important things for me when I'm assessing these patients. Definitely.
Yeah.
And I think Annie, exactly what you say is right. So if you've taken the history, you start to palpate pulses. If you can feel really strong pulses in feet and in their the popliteal, in their groin, if you're going up into the femoral, you can feel pulses the full length of that arterial tree. It's pretty reassuring that there's probably no significant arterial disease in that limb. And that, you know, you've got that background before you'll do an ABPI for completion.
Yeah.
But you've almost got that sort of reassurance before you do it. And even if you just were to put the Doppler on at that point and listen to the signal and hear a triphasic or really strong biphasic signal, that's very reassuring that there may be some minor arterial disease, but it's not significant in that.
No.
So you can hear these vascular nurses jumping in with these terminologies and expecting people to understand them. So we're just going to break a few of those points up. Within vascular, we like to feel a femoral pulse in the groin, a popliteal pulse behind the knee, and the foot pulses both behind the posterior tibial artery and on the dorsatus pes. We do that because what we're trying to do is to determine what level of disease is. For the diagnosis of peripheral arterial disease, the focus just needs to be on the foot. That's all it needs to be. Can you confidently feel a foot pulse? Yes or no? The problem is with palpation of foot pulses, it can be relatively subjective. Once you get used to doing this, you get good at doing this. If you're not, then it can be, can I feel it? Can't I feel it? Is that my pulse? So I think our one take-home message to you all is get used to and feel every foot pulse at any opportunity you have. Even if you're seeing a patient with a venous leg ulcer, have a feel of those pulses. Get to know anatomically where they should be, because it can be subjective. Jane spoke a little bit about arterial waveforms. So you can get a triphasic waveform. Annie, is a triphasic waveform normal or abnormal?
Normal.
Normal. And can you describe that to me?
Or do I have to sing it now?
Annie, you're Welsh, of course you do.
That's what it sounds like.
Choo-choo-choo. I love it. Love it. And that's when you can hear the systolic movement of blood from the heart, the forward flow, the slight reverse follow in diastole, followed by the arterial gurgitation / muscular contraction, and you get a little bit of backward flow. As you get older, that tone, that 3 tones, can turn to a 2-tone. Annie and the Welsh, would you like to do a 2-tone for me? Very good indeed. And that's when you lose that final resistance, if you like, of that arterial wall. Still a normal sound. And then finally, Annie, a monophasic sound. And that can be indicative of that there is some narrowing of the artery above it. The problem is with all of that is that can be really difficult to hear. Jane, are you good at hearing arterial sounds?
Probably not bad, Leanne, but there are certain, probably not bad, but they can vary a little bit. You know, if you have a very hot inflamed foot with infection, that can alter the arterial sounds as well. Yeah. And I've been on a ward round where we've argued about what the sound of, whether it's monophasic or biphasic, and that's with consultants, registrars and vascular nurses. So even within the team, it's not, we don't always agree on what the sound that we hear.
So we've said to you that feeling foot pulses is great, because if you can feel one, you can rule out peripheral arterial disease. It's quite an easy thing. If though you can't confidently feel it, you can listen to a Doppler, but again, it's subjective. So probably the best test to be able to do is some form of structured assessment of the perfusion of the foot. And Jane, what's your go-to method for that?
I would do an ankle brachial pressure index.
Yeah. Now, some of our audience might hear that and go, gosh, I got trained in one of those, and that's quite relatively difficult to do. I think we just need to demystify it. It's just a blood pressure, people. That's all it is. It's just a blood pressure using a Doppler, not using a stethoscope. So I'd urge you all to really learn how to do the ABPI, because it's a great objective measurement for patients to be able to determine that peripheral arterial disease. So we talked really about that immediate detection and how you can pull together that story that the patient's doing along with your clinical signs and symptoms. But I suppose we really have to concentrate today on what happens to those patients when they start to tip from that asymptomatic or claudication into that critical limb ischemia. So, Annie, what are the red flags that you tend to look for? In other words, who do you need to blow a whistle for and get to vascular as soon as possible?
So if I've got a patient that has presented with rest pain, I want to know about them. If they've had a non-healing wound that's been present for a couple of weeks that's not going anywhere. Obviously, if there's any necrosis, I want to know about them. And if they're really struggling with this rest pain and they can't cope with it, then yeah, I want to know about them. But I was going to say, we've got a really good thing to bring out that's got an excellent indicator on for those patients that are tipping over.
Fantastic. So Jane, any further information to say about that? And would you like to introduce the new SVN ring cards?
Yes, Leanne, thank you for that. We've worked together over the last few months in the SVN to develop some little credit card size ring card. I don't know if you can see that.
Oh, maybe closer.
Online.
Put it on the
Put it
front.
on your chest, Jane. There we go.
There we go. Yeah. Okay, doke. So these little cards, they have documented what we tell all of our patients when we've diagnosed them with PAD, but they're just for conservative management and best medical therapy. And we can come back to those terms. So when I send patients off, because they don't need to see me again, this PAD can be very well managed in the community by our colleagues. But I will ask them to look out for certain signs. And this little card documents those signs. So it talks about rest pain, infection, non-healing wound and gangrene. So if you have any of those signs, then please ring urgently to either your point of contact, that may be the vascular team, it may be your GP, it may be your community nurse or your practice nurse. So it talks about critical limb-threatening ischemia and when you need to act urgently, because time is of the essence. We have really tight windows of opportunity to improve things for patients and to save their limbs. And time is of the essence. So it is something that's urgent. And we've got some to give away tonight, lots of them free. So I think for the first 200 or so people that apply for it, we will send you 50 cards to use in clinic.
Excellent. So this is all about patient empowerment. So you've had a diagnosis of peripheral arterial disease. This is telling the patients what to watch out for and what to escalate as soon as possible. And you will see there's a link that's going on within the chat, I believe, that each and every one of you can get access to 50 of these free cards. It's limited to the first 200 applicants, but the SVN will send you these cards for free. And also, if you become a member of the SVN, you'll get a regular top-up of these cards delivered to your hospital base. And so please take an opportunity for that, because sometimes we think it's really hard for patients to be able to navigate the system. They might go to see their primary care because they've got a little ulcer at the size of the side of the toenail. And they go, oh, we'll just treat that with some antibiotics, when really it's that patient who needs to hold that ring card, show it to their practitioner to say, hang on, but I got told I had peripheral arterial disease, and if I got a wound, then I should come back to vascular. So that leads on to this question from somebody called Siobhan. Thanks for joining us tonight, Siobhan. She's put a great question in. How do you differentiate between a normal ulcer and tissue loss from chronic limb-threatening ischemia? Annie?
If you've got chronic limb-threatening ischemia, you more often than not will get tissue loss that presents on the foot. Now, if you can obviously investigate whether or not there may be reasons behind that, whether it's due to pressure or there could be other elements like diabetes, etc. But looking at that ulcer, if that ulcer is not improving, there's ischemic changes there, necrosis. If there's any extension in the necrosis, then those would be things that I would be worried about from an arterial point of view.
Brilliant. And most of these, so long as the patient hasn't got neuropathy, they'll also be in absolute agony, won't they? With it, and it's a key sign. And I think that, again, I wouldn't mind seeing anybody who's just got an infected parakinesia, a toenail infection. If they've got a diagnosis of peripheral arterial disease, I think they need to be seen by the right people to be able to determine how can we get that wound to heal. So the take-home point is a wound on the foot, especially of the digits. You be very, very mindful of that chronic limb-threatening ischemia. Emily has just popped in to say, when we were talking about differential diagnosis, she just said she's a vascular and MSK podiatrist. So she sees this real challenge in this differential diagnosis of these patients. Emily, I feel for you. I was in claudication clinic this morning, and some of it can be very tricky, but it's about putting together all those pieces of the pie, if you like, the history, the palpation, the pressure that you're seeing, and what do you think you're determining. But I am very grateful that we have access to investigations as well, such as arterial duplex scans, to be able to confirm or deny my diagnosis. And I must say, my biggest lovely cop-out ever, it's not coming from your arteries or your veins back to your GP. So I feel for you, Emily, because there's so many differentials in terms of musculoskeletal pain that's out there. Jane's popped in that we talked about a bit of arterial assessment, but she says it's a bit hard. It's harder on patients that's got edema of the feet. Any comments?
Yeah, it is hard to palpate with foot edema, and probably for those patients you accept that you might not feel it, and I might just use a Doppler probe and to listen to the quality of the signals for those biphasic, triphasic signals for those patients.
Do you guys still use burgers? Because I sometimes find that quite helpful.
Sometimes do, Annie. Sometimes, yes.
Oh, hang on. Look, they're throwing in McDonald's to you here, guys. All right. So, Annie, what do you mean when you say burgers?
So it's when you've got your patient on the couch, but you elevate their leg for a period of time. And if you see that that limb changes colour and goes to this waxy white appearance, then that would be an indication that there's simply not enough blood, arterial blood, getting to that limb. And then when you put it back down again, you'll get this bright ischemic rubor. So this redness will come back to the limb as it fills back up again due to the dropping of the leg.
And I use that commonly in patients who's presenting with ulceration on their feet, especially if there's redness, trying for me to determine, is that redness due to infection or is that redness due to hyperemia, which you're describing? And that elevation of the foot is a great little tip to be able to determine. If you've got a patient with a wound on a foot and a bright red foot, when you lift it up, it goes white, you send that patient to vascular. And Rebecca's added, so just in terms of swollen foot, I think the most important thing is make sure you've got the right Doppler probe. Most of us will use 8 megahertz. Well, you can only get for about a centimetre or 2. You might need a different depth of probe, because if not, you might be hearing a monophasic signal and you're just not close enough to the artery to be able to hear it properly. So just consider, have you got all the right equipment? And Rebecca's put in, apart from the obvious, is there a difference between feeling for a pulse and hearing for a pulse? If you can't feel it, but you can hear it, is that enough?
It depends on the whole clinical assessment again and the symptoms. So I can never just take one of those things in isolation. It forms the whole clinical assessment, and the patient story and the clinical examination forms part of it. If I can hear the pulse and it's monophasic and I can't feel it, and the patient has symptoms of peripheral arterial disease, then I'm concerned, because that's symptomatic, isn't it? And you certainly be putting them onto best medical therapy. But if I can't feel a pulse, but I can hear a biphasic signal and there's no evidence of any peripheral arterial disease, that's a very different thing. So in both of those settings, I may not have felt a pulse, but the outcome is very different because of the full clinical examination and the patient story. So it's, I
do have a bit of a bugbear, though, in the diabetic foot checks that happens across the community settings. That is, can you feel a foot pulse? And if you can't feel a foot pulse, that should go down as no. That is not, can I hear a signal in the artery? Because you can hear a signal, you can hear something from the most diseased of arteries. So just because you can hear something doesn't mean it's normal. No. If you're good at differentiating between the Doppler tones, it's useful. But you can't simply say, I could hear a signal on a Doppler, therefore it's normal. So I would urge you all, if you're doing annual diabetic foot checks, put your Doppler in the cupboard. The annual diabetic foot check is about, can you feel a pulse? If you can't feel a pulse, those patients do not need referring to vascular. Those patients just need consideration of how high risk are they? Do they need cardio disease protection, and do they need protection of the foot in terms of different orthosis to be able to protect that ulceration? And Vicky's just put in there as well about, have you got any hints or tips about how you hold the Doppler probe in terms of ensuring that you're getting that right signal?
I like a good bit of gel and 45-degree angle.
Yeah.
And what type of gel, Annie?
So ultrasound gel. It's got to be ultrasound gel, not your normal lubricant KY jelly, because you won't get the right sounds with that. You won't.
Yeah. And 45-degree angle and face it in the direction of the flow coming towards you. When you next get your Doppler out, play with it. Put it on 45-degree angle, then put it at 90-degree angle, and just listen to what it does. Put it on your brachial, listen to it. Listen to how it changes your signal and what's coming from that. We call it cropping the signal. Getting that really good connection is really vital if you're going to do that assessment of what waveform it is. So Claire's just put on, Andrew's put on, can pods get these cards? Of course you can. We might be the Society of Vascular Nurses, but we're very inclusive. Our ring cards are for all professionals of all backgrounds, so please apply for those and you can get those for free. Claire's put, she's had 2 patients with monophasic pulses, non-healing wounds and claudication pains. Vascular surgeons sent them both home saying they weren't bad enough for intervention. Weren't given any community intervention either. Any suggestions, girls?
So they have monophasic
pulses.
They have tissue loss to the feet.
Wounds.
Are there wounds on the feet?
I'm presuming so. Oh, toes, yes. So I think, Claire, that this.
And did they have a duplex scan? Did they have a duplex scan?
There is no information for us.
So those are the patients I would be, so there's certain things, isn't there? So some patients, you would investigate these patients. So I would request a duplex scan where we can have a look at the arteries. And then that scan would go to MDT where we'd have a discussion about the frailty of the patient, the appropriateness for intervention and whether we can do anything or not. If we can intervene with angioplasty plus or minus stenting, then that would often be our first port of call. And that's fairly low risk. Most patients can tolerate that, except very frail patients, perhaps patients with dementia for whom intervention is inappropriate, or patients who have terrible rest pain and maybe have to have their nerve deadened before they can lie for any length of time for an angioplasty on the table. The other option, of course, is revascularization, but that's major surgery, and it will involve a general anaesthetic, so they have to have pre-assessment. So I do wonder if those patients have gone through that process and maybe there's been a frailty issue or multiple comorbidities that have perhaps put that patient down a conservative management route or a palliative management route. So it's difficult to make a comment on that. Again, it's that whole patient story. And for some patients, it is about conservative management. Our patients are very comorbid. A lot of them are very elderly and frail. And for some patients, it's about really good pain relief, getting advanced directives in place where we can manage these patients well. And sometimes they're not for any intervention because that's not appropriate. So that may have been the case for your patients. I'm not sure.
The other thing is that everything we do carries a significant risk. And it may not be the right thing for those patients, as you said, Jane. And I mean, obviously, anything we do can increase their risk of amputation as well as trying to prevent it. And it's having those discussions with patients. And maybe that patient has already been through that process. I don't know.
And Claire, if you're a podiatrist, you might have heard of the Wi-Fi scar, which is a risk-based calculation based on the severity of the wound and the severity of the peripheral arterial disease that brings out a risk of amputation to that patient versus the likelihood of amputation versus the benefits of revascularization. That spews out a number. And if you're thinking, gosh, that number's high, therefore they're at high risk of amputation and there's a huge need for revascularization, the thing that the Wi-Fi score doesn't bring in is the nuance of the patient that Jane's talked about. It's about that patient's individual risks because nothing that we do is ever risk-free. So it's about that whole holistic assessment. What I'd urge you to do, though, Claire, is you sound like you're an interested vascular clinician. I would try to find your local vascular nurse and ask her for just to sit down and explain of why that is. Your local vascular team will help you to try to understand these nuances. We certainly want that that community engagement with all that what we do. So fantastic. Please keep sending your comments away. So I've just got one question though. So if you've got a patient who's got intermittent claudication, and you then set those patients off on a community path of maybe best medical therapy and exercise, when does that patient need re-referring back to vascular?
We're quite stringent about that, really. Yeah. I might never need to see that patient again. With good community input and optimising best medical therapy and exercise, that may be for about 70% of patients roughly with arterial disease, they need nothing ever doing. So for that's a grand proportion of patients can be managed well. However, if they have had their best medical therapy optimized, so they're on their antiplatelet therapy, they're on their statin, they've got all those risk factors optimized, they're doing their exercise, things aren't improving or they're actually deteriorating, and that patient's tipping into a significant short distance walking, or their quality of life is affected, that they can't work, they can't do their job, they can't carry out the normal activities, that is somebody that we would review again and reconsider. We've given them a good go with maybe 3 to 6 months of really trying to optimize things. And if they don't improve and it's affecting their quality of life to the point they can't work or they can't do the normal things, then we would review. We may not do anything further, but we would review that patient. And of course, any patients that tip into that CLTI bracket with tissue loss, rest pain, etc., then we want to see them back in clinic. But for the majority of patients, we don't need to ever see them again.
So you hold that thought for a minute, Jane. I just want to bring up what's happening in the chat. So Jill Sykes says she loves the Burgers test. Eileen says, but what about patients with darker skin tone? And then Helen's put, but what about patients who's got venous congestion, because that can make it cold? Absolutely. We love the test, but it's like anything else. I don't think there's one test that's standalone good. I think that what the diagnosis of all of this is, it's about, first off, that strong patient history, along with all of those parts of assessments that can help you build up that ultimate diagnosis.
It's like a jigsaw puzzle.
Indeed, it is like a jigsaw puzzle. I quite like that. So Martin said as well that you can listen to the pulse while doing a Burgers test to see what type of when did the sound fade. Yeah, I've seen that being done, but truthfully, only by very, very detailed vascular scientists. We just tend to not look at with the Doppler in terms of the arterial pressure. We just look at the colour change. Do you two use the Doppler in that way?
I have done. I think it's known as the pole test, isn't it? If you'd call it by its correct term. And it's just about the degree of the angle of the leg, how far it's raised. You have to remember these are very frail patients and they can't all sling their legs over their shoulders. So you do have to be quite cautious about raising some of these legs. But I have used it when I haven't been I have no conclusion from my assessment. I have added that in, and it's usually for patients with probably monophasic signals, and I just want to try and clarify things a little bit further. So yes, Martin, I agree, I do sometimes use it.
And then there's just a little bit of a question about electronic Doppler devices, electronic ABPI devices. What are your thoughts on these? Because at the moment, Shona's using them. She's doing that first line. If unsuccessful with that device, then she goes to a manual. But she's using those for, presumably, ease and speed in the first line. What's your thoughts, Annie?
I prefer the old-fashioned Doppler, because I like to hear. My Doppler's got waveforms on it, and I like to see the waveforms as well. Obviously, the guidance that came out shows that there needs to be more work around it, really, and that they're okay for use in research. But if that's all you've got, then that's all you have to use. That's what you've got to use. And certainly we've got a lot of places here in community settings that's the only access that they've got to be able to do an ABPI. So, that if that's all you have, then that's what you've got to use.
Andrea made a comment there, just saying that about NICE. You're absolutely right, Andrea. NICE did say not to use them except with sort of research base. And as we gather evidence, and maybe that will change in the future, but it's about gathering evidence in your practice to support or refute the use of automated ABPI machines.
And I would look at that NICE guidance with the detail is needed. So NICE said it shouldn't be used routinely for assessment in patients with leg ulceration. It does not actually look at any evidence about how good it is at being sensitive and specificity, I can never say that word, about detecting peripheral arterial disease. They have a lot more evidence base about the detection of peripheral arterial disease, and that's the nuance of peripheral arterial disease is at 0.9 versus you're allowed strong compression up to 0.8. And actually, when NICE looked at it, there was very little studies done on patients with ulceration on the leg, and that's why they came out with those recommendations. To me, I think any tool that helps a patient get through the pathway to the right people at the right time is the right tool for you to use. Emily's mentioned that on the National Wound Care Strategy form, there is a frailty index. Yes, there is on the back of that, and it can be a really useful aid memoir. But frailty is difficult to assess, and but it's that Rockwood score that's on the form is really nice. But in vascular, there is so much more that goes with frailty in terms of their anaesthetic risk. So quite often you'll end up with doing patients with pulmonary function, echoes, and looking at their overall anaesthetic risk because of it's that balance of those patients. We've got a great question from Rebecca, because I mentioned it. I mentioned hyperemia, and she said, how do you diagnose this as a difference of dependent ruber? They're not different, it's just different terminologies. Dependent ruber is a hyperemia, but you can get hyperemias for other causes, not just peripheral arterial disease. But Rebecca, you're probably at the end of my knowledge with hyperemia, so I'm going to very quickly skip over that one, if that's okay with you. So we mentioned quite a bit about the options in terms of management of these patients. So you see a patient in your claudication clinic, they have short distance claudication, 100 yards, you've taken a good history, you can't feel a foot pulse, you've got a reduced ABPI with a monophasic signal, you're happy to give that diagnosis of having intermittent claudication. So what are the cornerstones of that management of that patient there and then? Who wants to go first?
It's a bit different in Wales because we're very lucky, certainly in my area, that we have access to National Exercise Referral Scheme. So I can refer my patients to pop along to the gym, and they're seen on a weekly basis where they meet with a exercise physicist, as they're called, and go through walking exercises. And then I can get a report back then in about 6 months' time to see how they've got on, whether or not they've managed to tolerate it, as their walking distance increased, things like that. And the other thing that I love to do is give them the Circulation Foundation leaflet, because that is brilliant.
Yeah, we'll be putting a link on that any minute now about that leaflet for that exercise, along with that patient information that's on that site. So absolutely, exercise is key. And that exercise is about, if your motorway is blocked, how can we stimulate you growing new B roads? Angiogenesis, that big word that Jane says, and those new B roads are stimulated by the release of nitric oxide in that muscle at exercise that helps to stimulate those. And that's truthfully what gets a patient out of trouble. If you can grow collaterals, you are highly unlikely to develop critical limb ischemia. And that's why exercise is number one. But Jane, along with the exercise, what else is vital in this patient group?
So you need to lower the cardiovascular risk. For me, it's that. So it's a two-pronged approach, really. Improve walking ability and lower cardiovascular risk. These patients are more at risk of heart attack or stroke rather than really going on to lose a limb for many of them. And so it's absolutely vital that we encourage them to make those lifestyle changes and we optimize that medical therapy. So it is, and we ask these patients to do an awful lot of work themselves with their lifestyle management. They need support, but at the end of the day, it's them doing a lot of the hard work. There's no magic pill that's going to do it for them. And it's about, I do think in community, you're so much better at this optimization of cardiovascular risk than we are as vascular nurses. I think you excel at this. You keep a tab on their HbA1c, you keep a tab on their blood pressure, tight control, you keep a tab on their cholesterol levels. So I think you do this so much better, and you do excel at this. And I just take my hat off to my colleagues in the community who do this so very well. So yeah, I think it's that two-pronged approach really to manage these patients long term.
But we really need that focus on that, don't we? Because the best thing they can do with these patients group is to get their cholesterol, their LDL, down to 1.6 millimoles per litre if you can. And to be able to do that is a tricky devil, isn't it? It requires titration and additional medication. But I think we can't focus on what a huge role that takes. The NICE recommendations is clear that we should get every patient with peripheral arterial disease on clopidogrel 75 milligrams unless contraindicated, along with atorvastatin 80 milligrams. No baby doses of statins, 80 milligrams, but with a tight control aiming for 1.6 LDL or below. And if you can't get to that, then you should think about how other drugs can come in, such as ezetimibe, and even referral on for familiar hypercholesterol clinics who've got access to now monthly injections to be able to reduce your cholesterol level. But I think that's really vital. And I think us as vascular nurses, the patients often come to us wanting us to revascularize and improve my leg. And sometimes that can be a hard sell. What's your top tips when you're talking to your patients about how it's really important about those cardiovascular risk managements?
I think it's really hard to manage their expectations. Well, you're right. When they come to clinic, they expect you to have that magic pill and to sort it out. But when you sit, and I think we're lucky as vascular nurses that we have that time to sit in our consultation and discuss with them exactly what is happening and the things that they can do to help themselves. And I think that's the big hard sell for me, is spending that time and explaining to them what's happening inside your body. These are the things that you can do to help yourself. Stop smoking, make sure that you're taking the right medication, listen to the advice that we're giving you about walking, because if you don't do that, you will be back.
And I think it's about that consistency of message. So no matter which practitioner they see, which setting it is, whether it's a podiatrist, a physio, a nurse, that it's the same drip feed of this is what you need to do. And I think that's where the collective power comes in. Just a few comments that I've just got to mention. Emily says Wi-Fi is like a foreign language between vascular surgeons. And she says it's like they speak French. Absolutely, Emily. The vascular surgeons only learned French over the last 5 years, and now they're all toe pressure obsessed, which is interesting, working in vascular, I can tell you. And Hannah did point out a point that on the ring cards, we did say to contact your GP within 5 days. She's saying she can't directly refer. Now, Hannah, I don't know who you are, but within our vascular service, we would accept a referral from anybody. A physiotherapy, a nurse, a podiatrist. If you thought a patient had critical limb ischemia and they already had a diagnosis, or even if not, of peripheral arterial disease, we would accept a referral from you. Sometimes this is just a unknown folklore that you think that we won't. Try referring and see what happens, because most good vascular centres would accept a referral from anybody, especially somebody that sounds in the know that's taken a good patient history. Anna, you've mentioned in Wales you're very fortunate to have a exercise support, if you like, but Carmel points out that not every community has access to that. So there's a question of who runs them for you, and I suppose there's a secondary question from me. What happens if we haven't got one accessible?
So there's money that's paid in by the local health board. It's the same as cardiac rehab. So we have lots of classes for cardiac rehab, and then we also have access then to the leisure centres. Some patients, depending on which borough that they're from, they may have to pay £1 to attend the leisure centre, but it is available and it's accessible to them. Lots of them are run as well by we would have GPs referring patients with depression for a session at the gym or something like that. So it's a similar sort of system like that we operate under. But we are very lucky.
Yeah, you're fortunate. Jane, do you have one?
We don't. We have them in patches. So we have very keen like OTs and physios who run them in various little community hospitals, which are rehab hospitals, and they've taken a particular interest. But that's not equitable right across the county. What we did used to be able to do was piggyback them onto the cardiovascular rehab. We've done that for years, and after COVID, that kind of just died a death. And it's something that my colleague and I have looked into, and we probably should try and pursue that a little bit more again. I think one of the problems is, Annie, is the actual physical uptake of our patients. A lot of them, it has to be very close to their home base, doesn't it, for them to want to go. And a lot of them are quite elderly and they don't always want to go. But what we've done is we've accessed things like Fit for Life, simple chair exercises for some of our patients. So we've sort of had a look at our local community, what's available in sort of community centres, etc., and try to get information that we can give to patients to point them in that direction. So a lot of the time we're just sign pointing patients into exercise programs, but we do have one or two that we can refer into, but it's not equitable.
I mean, you've got some patients that they don't want to go to the gym, like say it's embarrassing, they don't want to join in. Well, I will often say simple things like, well, try and go for a walk around the block. Measure yourself from lamppost to lamppost, and then see over time, then are you able to reach another lamppost in time? And then, if you feel comfortable doing that, then that'll be your exercise, but try and do it every day.
And in tight Yorkshire, you've got no chance of getting any form of exercise. My advice is that Circulation Foundation leaflet, and I tell them to set themselves a circuit, just like you said, Annie. And I say to them, you notice when that pain comes on. If that's at Fred's gate, tomorrow I want you to get Fred's gate plus 10 more steps. And I want them to train themselves like an athlete, if you like.
Yeah.
Because you've got to remember two things is happening. You're encouraging that collateral growth, but you're also getting that muscle used to using less oxygen. You know, Mo Farah can run a marathon. He's got no more arteries than us. He's just, that muscle's been trained to use a lower threshold of oxygen to get that much power out of them. And claudicants can do the same over a long period of time.
I think they get frightened of the pain though, don't they? And it's reassuring them that the pain is not dangerous.
Yeah, because anything else, Annie, if you get pain, you're told to stop doing it instantly, aren't you? And, you know, and I do think that's a barrier. You know, I join a gym every January and I fail to go every year. I've got a million excuses and I don't get pain. And I think that's where we really need to be focused on that wider intervention of motivating our patients to really own their own health and really be responsible for their own health. And I think that's quite difficult. So hang on, look, there's questions coming in all directions for me. Hang on. So just going back, what's the best probe? 8 milligram is the one that you're buying, but you can get a different one, and you'd be better looking at one of the companies in terms of which is the best kit available for you. And there's some other questions in there that I'll come back to whilst you're talking. I'll just have a quick read of those. So I think we've sort of covered that this needs to be a team sport. We've sort of covered in terms of when to refer to vascular and when not. There's a couple of other bits that I just wanted to talk about. Smoking cessation. What do you think of vapes? Is it a good thing or a bad thing?
Ooh.
I think the jury's a little bit out, Leanne, still, isn't it? I think it's a little bit out. I mean, we're always delighted when patients stop smoking, and when they stop completely, that's fabulous. But what we do find now more and more is that they're replacing it with vaping. And I do encourage my patients to consider stopping vaping. And maybe more from the long term. We don't know the long term, I suppose, implications from lung damage even, or atherosclerosis is often an inflammatory response, and I just don't know if vaping is going to create that inflammatory response within the arteries as well. I don't know the answer to that question.
So what I preach is stop the tobacco, and if you can stop the tobacco to replace the nicotine with a vape, great. But I also want you to stop the nicotine, and if you have to do that in phases, do that. And certainly it's the tobacco which is the most damaging. Nicotine's still got a question mark over it. It's not good for your arteries. And ideally we want them on nothing. And we don't know what's the secondary outcome of all of this. We could be getting a different type of lung disease that we've never seen of before. I
think what you said is absolutely right. It's like, don't stop trying to stop. And that's what I say. You can take multiple attempts. Don't get disheartened. Have another go at giving up again. You take multiple attempts for many patients to actually stop smoking.
Yeah. So there's a quick question from Joe about pain relief. So we don't recommend pain relief for the intermittent claudication, actually. No analgesia really help you. We only do pain relief if patients are suffering from chronic limb-threatening ischemia. It's a troublesome pain to manage. Annie Jane, any tips of where people should start for chronic limb-threatening ischemia pain?
I think it's misunderstood, isn't it? I don't know if you'd agree, Jane, but I certainly have lots of patients that come to clinic and they say, I can only get paracetamol. This is ischemic rest pain, and this needs to be treated with something hard. So generally, most of our patients are either on oxynorm or Oromorph.
Yeah, and often we bring them in actually prior to revascularization to get them to nerve block them so that we can reduce the swelling of their leg and sort of prep them ready for if they're going to have bypass surgery, and to give them some relief. It's it's relentless pain. It's unremitting. It's awful pain. Really, there's nothing touches it, and often you need so much pain relief that it actually knocks patients out for 6 to get on top of that pain. So their quality of life's gone.
Yeah, we have a CLTI pain pathway. If anybody does want to have a copy of it, you're more than welcome to. Ours starts on a background of paracetamol. Don't forget how powerful paracetamol is if you take it 4 times a day. It then steps you up to codeine, along with the potential gabapentin and some amitriptyline on a night time to aid the sleep. Then it tips over to opioids in terms of Oromorph and titrating that into some form of patch. more than happy to share that. You just send something in the chat with your email address, and I'll send you that CLTI pain pathway. Obviously, that's local to our organisation, but it's something that we've done to help to standardise, especially standardise how does community escalate to the next pain management if our initial pain management hasn't helped that patient. And gosh, there's just so much going on in all of these chats, girls. It's absolutely amazing. And somebody has put that they refer their patients of CLTI to the on-call vascular service. They've also put they refer acute limb ischemia to the on-call vascular service. Absolutely, acute limb ischemia should be referred to your on-call vascular service. But CLTI, Jane, Annie, would you expect that referral to come as an urgent outpatient or to the on-call team?
We probably see it as an urgent outpatient and try and get them into a hot clinic. However, if it's been a chronic that's just tipped suddenly into sort of acute on chronic, then again that would go to on call. So I guess it depends on how the patient presents, but we would try and facilitate a hot clinic really to manage those patients initially.
Yeah, and I think most of the vascular services now up and down the land have got access to acute slots within a hot foot service. So we have 3 clinics a week to see our urgent CLTIs. The target is we've got 14 days from you referring to revascularization. That's the national target. Our on-call, I don't think, would be thanking you, but it depends on how you've locally got it set up. If that's your access through the on-call to your urgent hot foot clinic, that's the right thing to go. I think it's just about local nuances of referral process. And I think that's why it's really good that if you're interested in vascular, make friends with your local vascular surgeons and your local vascular nurses. You are welcome to any clinic up and down the land. I can tell you, to get in a vascular surgeon's clinic, all you need to do is buy them a latte and a bun, and they will welcome you into that clinic. The SVN is happy to support you in terms of making that and reaching out to contacts to your local vascular teams. So I can't believe an hour's gone already. I haven't touched half of these questions that we've got, and I'm sorry if you put a question in that I haven't had a chance to answer. I can see there has been a couple of specific patient questions. We just can't answer those. I'm sorry. To be able to give per patient advice, they need to be under our care. So I'm sorry that we haven't been able to answer those. If there is some specific advice about your family, please put that into Legs Matters, and we'll try to give you some generic advice that might help to navigate you and your dads through that process without a problem. Vascular is about a team sport, and we need each and every one of you out there to be playing the game with us. We are a friendly bunch, so please carry on your amazing job. We need you to identify these patients within a community setting, and most importantly, escalate those who need to be seen by vascular in a timely fashion. So if you're interested in all the Society of Vascular Nurses do, please think about joining us. You can join as a nurse member, or you can join as a non-nurse affiliated member to our society. So I would like to thank my brilliant colleagues for joining me this evening. Thank you both.
Thank you, Leanne.
I'd like to thank Legs Matters for allowing the SVN to take over your space once again. We do love you so much. And just don't forget, continue to be being that amazing vascular champion for your patients and your population.